Good afternoon. Welcome to Grand Rounds. Today, please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluations. Give us any ideas in regards to future topics or future speakers. Today, I have the pleasure of actually reintroducing Geoff Wall, who's provided us with two really outstanding previous Grand Rounds presentations. As you may recall, he received his Doctor of Pharmacy degree from Idaho State and currently wears several hats, including being a professor of clinical sciences at Drake, director of the Drake Drug Information Center, associate professor of pharmacy practice at Drake, internal medicine clinical pharmacist at Iowa Methodist, and clinical assistant professor of pharmacology physiology at Des Moines University. And he kindly has accepted our invitation today to come down and come up and provide us with a review of non-IgE mediated drug hypersensitivity reactions. And please join me in re-welcoming Geoff Wall.
Thank you very much. I guess either you guys are fascinated with drug allergy or you're not sick of hearing me talk yet, so that's good. Either way, it's good to hear. I'm glad I was invited back. So I was asked to talk today. We had spent the last Grand Rounds I'd given for you guys was just a general overview of drug allergy and antibiotic allergy. And as I understand it, there was some interest in kind of digging deeper and talking about drug reactions which are less common than your common rash, hives, that sort of thing, but definitely do occur, and when they occur, they can be pretty serious. And so what we're going to focus on today are hypersensitivity reactions that are not mediated by immune globulin E, which means these aren't going to be the ones that are usually associated with things like hives and anaphylaxis and angioedema and things along those lines. So the objectives, we're going to talk about, and there's a whole alphabet soup of names and acronyms of syndromes that kind of talk about drug hypersensitivity syndromes. I'm sure most of you have heard of DRESS syndrome. That term is kind of falling out of favor, and so now they're trying to call it other stuff. But whether you call it DRESS syndrome, hypersensitivity syndrome, drug-induced hypersensitivity syndrome, they all kind of talk about a general set of symptoms that are caused by a drug that can be very serious, as many of you know. We're also going to spend a significant amount of time talking about acute interstitial nephritis. That is often caused by drugs, and it's something that we always worry about when we have someone with acute kidney injury, and the diagnostic approach to that, which again, I know we have at least one nephrologist in the audience probably knows real well. Make sure we're kind of all up to date on that, and some of the drugs that can cause it, including one that may surprise you. I'm kind of like the clickbait on Yahoo. So this next drug may surprise you. We'll see. So as we all know, there's two types of adverse drug reactions, right? Type A reactions are reactions that, in a word, are based on the pharmacology of the drug and can be predictable, right? So someone who has a side effect of bradycardia because they were put on metoprolol, that would be a type A reaction. It's predictable and dose dependent. The person who's on more metoprolol is probably more likely to have bradycardia than the person who's on less metoprolol. Obviously, we're not going to talk about that today. We're going to talk about type B reactions, which are hypersensitivity reactions. We talked about this in some detail in my last Grand Rounds. And the big difference is that they are unpredictable. You don't know who's going to get them and who isn't. They're not dose dependent. They can occur at doses below the therapeutic dose of the drug. And they comprise about 10% in general of all serious ADRs that are reported to major reporting people like the European Union and other places that collect this kind of data. So ADRs in general occur in about 10 to 20% of hospitalizations. Sometimes I wonder about that number. I mean, that number could be high or low depending on where you sit, I suspect. About 5% of people are hospitalized due to adverse drug reactions, it's estimated in the United States. And again, we're going to talk about fairly rare manifestations of drug allergy today. So we're not going to talk about, again, the run-of-the-mill maculopapular rash, which all of us have seen probably multiple times, or the hives and itching that people complain about. We're going to focus on the cutaneous drug reactions that often do have other organ manifestations that are rare, but when they happen, they can really be devastating. Again, fortunately, only about 1 in 1,000 patients complain of that or have it happen to them, but when it does happen, it is devastating. And just speaking, it's always funny how timing works out. In my medicine service, we actually just had a patient just last week who had a classic Stevens-Johnson syndrome as a result of starting lamotrigine. I haven't seen one of those in years, and it was like 3 doses in, she busted out into a big rash, came to us, and we ended up having to transfer her to the University of Iowa because of ocular involvement that we couldn't really deal with at Methodist. So you don't see these often, but when you do, they really stick out in your mind. So this was the chart I had at the drug allergy talk last week, and it lists all the different drug reactions and the types based on the modified Gell and Coombs system. Remember that Gell and Coombs came up with a system of predicting drug allergy based on their purported cause. So type 1 reactions we know are caused by immune globulin E, and they tend to cause things like urticaria and anaphylaxis. We're not going to focus on really anything but what's in the barred parts of the graph, so we're going to focus a little bit later on talking about type 2 reactions, which acute interstitial nephritis is often labeled under, and then we're also going to talk about type 4C reactions, which are mediated by cytotoxic T cells, which falls under all these desquamating skin reactions like Stevens-Johnson syndrome, toxic epidermal necrolysis, and things along those lines. We're gonna go through all of that as we go along here. So in this case, then, what we mean by a drug hypersensitivity syndrome is a patient who has a kind of a constellation of symptoms, and they usually, but not always, meet most of these symptoms. The first is a big desquamating blistering rash. So this isn't the kind of regular maculopapular rash that we've all seen in a lot of people. It sometimes isn't even itchy for patients. They can be red from head to toe, and you're like, well, are you itchy? And they're like, no, I'm fine. They just look like they're have a red rash all over them. This is different. This is going to be blistering or desquamating rashes where you see blisters and bullae, and where the skin will literally fall off like in a bad sunburn. They will often have a number of other constitutional or organ-based symptoms, including fever, confusion, and then either acute kidney injury or acute liver failure are common with all of them. So that is what we're going to be talking about when we talk about hypersensitivity syndromes. And one of the confusion in studying this is the many different acronyms by which this is termed. The original one, the one I was taught, and one I'm sure you've been used in your careers, is DRESS syndrome, drug rash with eosinophilia and systemic symptoms, right? So this is someone who has a bad desquamating rash, their serum eosinophil levels are high, and then they have some other organ-based problem like acute kidney injury or acute liver failure. Then in the 1990s and 2000s, they said, well, they don't always have eosinophilia, so maybe we should take that out and just call it drug hypersensitivity syndrome, but that seemed to be too broad. So now the preferred term is drug-induced hypersensitivity, or DIHS, and that's what, if you read the literature nowadays, that's the term that they're trying to say is the standard term that we're using for a desquamating skin reaction with some sort of systemic or organ-based effects as well. So when is this likely to occur? Well, it depends on the drug, of course, and it depends on the patient, but most commonly you're going to see this not occur immediately. Remember that IgE, by its nature, will cause reactions within the first dose or two. This is going to be caused by cytotoxic T cells, and that's going to take a while for the immune system to get revved up, recognize the drug and the organ as foreign, and attack it. So this usually manifests weeks after starting a drug, okay? So this is something that usually will not happen immediately upon taking the drug. There are some exceptions, obviously. And certainly re-challenge, once the patient has been sensitized to the medication, that may cause more severe reactivation and sooner, okay? Now, all that being said, you can search the literature, and there are case reports of people who have reported drug-induced hypersensitivity syndrome for patients who have been on drugs for years. There's reports of people, for example, who have been on allopurinol for gout. They've been on it for 5 or 10 years and tolerated it just fine, and then one day they started having symptoms that looked like drug-induced hypersensitivity syndrome. So there are reports of that, but on the whole, 2 to 8 weeks is what you should normally see. They usually develop a fever and that rash, which is pretty common, and that occurs pretty early in the development of the disease. And then also lymphadenopathy is quite common. Something about 70 to 75% of patients will get, especially axial lymphadenopathy with the development of the rash. So again, those are things, diagnostic clues to look for. If you suspect that, if this patient has a syndrome or a skin rash with the fever that has you suspect a drug-induced hypersensitivity syndrome, be sure to follow up and say, hey, we better check a comprehensive metabolic panel and see what your creatinine's doing. We better check a liver panel, see how your liver's doing, things along those lines, just to make sure that you're catching all of the potential organ involvement. Now, there is actually an official European body that deals with this, and the body is called Regiscar. It's the European Registry of Severe Cutaneous Adverse Reactions to Drugs. That's a big mouthful, so I'm glad I'm just going to call it Regiscar from now on. This is actually a great website to go to if you're interested in these kind of drug reactions, and they actually have specific diagnostic criteria for the different types of drug-induced hypersensitivity syndromes. They also have a great database that you can just punch in a drug and say, has this been reported to you guys as a cause of drug-induced hypersensitivity syndromes? And you'll get a little report saying, yes, this has been reported 5 times to us in the last 5 years, sort of thing. So I mean, that can sometimes help as well. But what Regiscar says is that you need to have at least 3 of the following, and note that they do note in their own document that a skin biopsy to help the diagnosis is helpful, but not always necessary. Hospitalization, obviously a drug reaction, reaction is expected to be drug-related, an acute skin rash, fever, enlarged lymph nodes at least 2 sites, involvement of at least 1 internal organ, and they note that hepatitis is actually the most common thing you're going to see in about 50% of cases, and then either low platelets or raised eosinophils, and they actually count eosinophils as anything above 10%, and they see that in about 30% of patients, or an abnormal lymphocyte count. So if you have at least 3 of those things, you can help make the diagnosis of a drug-induced hypersensitivity syndrome. What drugs cause it? Well, do you have another 2 hours for me to sit here and just spout off a whole bunch of drugs? Because that's what it would really take to do. I mean, you know, multiple drugs have either been reported in their package inserts or just in the literature as causing some sort of syndrome, whether you call it DRESS or drug-induced hypersensitivity syndrome, it doesn't really matter. That being said, there are some pretty notorious culprits, and probably 2 that lead the list are sulfonamide antimicrobial, so Bactrim, things along those lines, and aromatic anti-epileptic drugs, which are drugs that I don't think anybody uses much anymore because we have newer drugs, but we still do have people on Dilantin, Tegretol, and phenobarb. So those are the aromatic anti-epileptic drugs. All 4 of those drugs have been noted to have a fairly high incidence of these drug-induced hypersensitivity syndromes. Now, again, by fairly high, you note that it says 1 in 5,000. So again, it's not common, but you know, these are the drugs that certainly my colleagues and I, if we suspect this, those are the drugs that are really going to sit out at us as probably the most likely cause of these reactions. The other piece, and this is kind of relatively new, is the interaction between pharmacogenomics and drug-induced hypersensitivity syndrome, which is actually beyond just the theoretical stage with several medications. So, and this all goes back, and I'm sure all of you have heard or read about the whole notion of personalized medicine. And unfortunately, personalized medicine right now is a great idea in theory, but in many cases, the actual implementation of that is still a little bit hazy. This is one case where that's not the truth, or at least for a couple of drugs. We know that your ability to metabolize medications is determined by basically your genetics. Your genetics will determine, for example, what type of cytochrome P450 enzymes you have and at what percentages you have them. And some people are just genetically predetermined to not have very much of a certain enzyme or produce a certain amount of enzyme. In those patients who get drugs that would be metabolized through that pathway, that drug is going to build up because it can't be metabolized into a non-toxic form, okay? And so because of that, in some cases, and I think for some of the drugs we're going to talk about, patients are more likely to develop a drug-induced hypersensitivity syndrome to a medication because they're genetically unable to metabolize the drug into its non-toxic form. That's terrific, but how do we operationalize that? So, I mean, that's great in theory, but it has actually been looked at. Well, actually, in some cases, it has. And here's a nice chart, and I assume you'll have access to it. In particular, 2 drugs I wanted to point out are drugs that, again, I think most primary care docs do see at least occasionally, and that's allopurinol and carbamazepine or Tegretol, right? We know that both drugs have been noted to cause drug-induced hypersensitivity syndromes, as well as just general Stevens-Johnson syndrome and toxic epidermal necrolysis. Well, interestingly, patients' ability to metabolize both allopurinol and carbamazepine to non-toxic forms is genetically determined, and it's based on that HLA allele there. So if you have a mutation at that HLA allele, you will not be able to metabolize allopurinol or carbamazepine into its non-toxic form. Okay, well, you're not obviously going to test everybody who comes into the door with gout that you're going to put on allopurinol. So do we have any other thing to go on? Yes. Those mutations are much more common in certain populations, in particular Asian populations. So for allopurinol, patients of Han Chinese descent, Thai Japanese descent are much more likely to have that mutation at the HLA B58 site on the HLA or MHC complex. Drug eruption, there are some other ones as well. For carbamazepine, again, mostly of Asian descent, Indian, Thai, Malaysian, Han Chinese, et cetera, Japanese, but Caucasians are in there as well, and actually they're in on both of them, though they're much less. So bottom line is, if you have a patient of those descents that you're going to start the drug on, they're probably at a higher risk of developing drug-induced hypersensitivity syndromes than controls. Okay, you said probably. So I mean, is that true? Is it we're just thinking about it? Well, the FDA actually thinks it's true because this is in the package insert of both Tegretol and allopurinol. So if you read the Tegretol package insert, it says, prior to initiating Tegretol therapy, testing for HLA-B 1502 should be performed in patients with ancestry and populations where that may be present. So again, if you had an Asian patient that you're going to start Tegretol on, it's probably a good idea to do that test. Same with allopurinol. 2012 ACR guidelines for gout say test for HLA-B 5801 in patients who you think are going to be at risk for developing drug-induced hypersensitivity syndrome with allopurinol, and they note in particular individuals of Korean descent. So again, you're not going to test this on everybody, but if the ancestry dictates it, it's probably a good idea to do that test. Now, of course, that's going to be a send-out test. We probably don't do it here at Mary Greeley. I know we don't do it at Methodist. It's probably going to take a while, and it's probably not going to be cheap. But if it avoids a case of Stevens-Johnson syndrome or toxic epidermal necrolysis, it's probably going to be worth it. And given the fact that it's in the package insert, I would also argue there's probably some medical legal implications there were that patient to develop those and you did not test previously. So. Other drugs that are involved in drug-induced hypersensitivity syndromes, again, are as long as your arm, and we could spend an hour just relaying them. I've already talked about allopurinol. I've already talked about the aromatic anticonvulsants and sulfonamides. What are some other drugs that have been noted to cause it? Lamotrigine, and as I said, we just had a case of that just recently. Several of the HIV drugs, though we don't use some of these as much anymore as we used to. Diltiazem. I've actually seen 3 cases of either Stevens-Johnson's or toxic epidermal necrolysis with DILT. And that's not a drug that usually comes to the top of the list as people of drugs that think that are caused with super bad allergic reactions. Bottom line is there's many others. And if you want to do a search, again, what I'd recommend to save yourself time and maybe get a little more accurate going on, go to that Euroscar website. I've got the link at the bottom of that slide. Go to that website if you have any question about is this patient's drugs causing some sort of weird hypersensitivity reaction. That's probably going to give you your best data on that. What does it cause? Well, like all hypersensitivity reactions, we don't exactly know, but we know that it probably has something to do with activation of the immune system, falsely identifying a drug or its metabolite as foreign, and then tagging it, targeting it, and then targeting with a complex targeting either cellular proteins or tissues that leads to an autoimmune response. And so again, it's the skin that's often affected, the liver, the kidney that is often affected. Is there anything else that puts you at risk for this? Yeah, actually there's some data that suggests that patients who've been infected with herpes virus 6 may increase the chances of developing a drug-induced hypersensitivity syndrome, maybe because that pathway of the immune system becomes charged or activated with the infection of HHV6. So that's drug-induced hypersensitivity syndrome in general. Let's break it down now into actual individual entities inside that. So just for all of us thinking together, this is your general mobiliform drug reaction, and we've all seen this. It's your standard maculopapular reaction. This is unusual in that it's on the hands, though if it is on the hands, it's usually on the back of the hand. Really remember that the palms, the soles, and the face are almost always spared with maculopapular reactions. This happens with 1 million drugs. I've seen it 10,000 times. You probably have too. And the good news is if you stop the drug, this usually goes away, and there's almost never any systemic involvement, and people do quite well. A cousin of that is erythema multiforme major. And erythema multiforme major is on this kind of long line of desquamating skin reactions that kind of starts with EMM and then goes all the way to toxic epidermal necrolysis. And the farther up that line you get, the worse the skin involvement and the worse the mortality associated with it. So EMM is a little bit different in that they're similar lesions, but they predominate over the extremities. And the big difference between EMM and Stevens-Johnson syndrome and toxic epidermal necrolysis is that EMM is not usually caused by drugs. EMM is usually caused by infections, especially herpes infections and mycoplasma infections, and people do well with it. They usually have a benign course. So here's an example of erythema multiforme major. So again, it kind of looks like you're getting these target lesions that may desquamate, that they may actually fall off, and they look kind of blistery, but there's a big difference between that and this. And again, the key difference is that they had some sort of viral, a syndrome, upper respiratory syndrome, something along those lines that may lead you to think if they've developed this afterwards that this is probably related to the infection and not the antibiotic they may or may not have been put on correctly or incorrectly. That, again, is part of the syndrome or part of the line that can include Stevens-Johnson syndrome and toxic epidermal necrolysis. And what's the difference between them? Well, Stevens-Johnson syndrome and toxic epidermal necrolysis are different than what we've just seen in that epidermal detachment occurs very commonly. The difference between SGS and TEN is just how much epidermal detachment occurs. And Stevens-Johnson syndrome, it occurs when less than 10% of the skin is affected and causes desquamation. TENS occurs when more than 30% of it is, okay? So again, as I've gotten the slide here, the big difference then between Stevens-Johnson syndrome and TENS and EMM is that EMM is almost always caused by infections and can run a benign course, whereas these other two entities are almost always drug-induced and can usually be fatal. When do they occur? Well, they can occur fairly rapidly, but they usually occur about 1 to 4 weeks after exposure. So again, it takes a while for T cells to be activated to activate the immune system and lead to the skin responses associated with these entities. What will you see with Stevens-Johnson syndrome? They start off with kind of purpuric macules that will then pretty quickly blister. And so the big difference between the maculopapular rash we saw here is you're going to see a confluence of redness and blisters all over the affected skin, okay? It usually starts off in the trunk, and different from maculopapular involved rashes is that the face is very commonly involved as well, including mucous membranes. And mucous membrane involvement is actually one of the worst problems that can happen with these patients, especially the eyes, because you can actually get permanent blindness depending on the damage done to the eyes with these two things. Mouth involvement is also very common. The patient that we had at Methodist with lamotrigine-induced it, she had very bad ulcers in her mouth, and my team was like, so we're pouring magic mouthwash down her throat every 2 hours, and she can't eat because she's complaining of so much pain. What do we do? And I said, Carafate suspension. I mean, we were basically trying our best to do something for this poor patient. But mouth involvement is also very common, and other mucous membranes as well. I hope you guys have all eaten, because now I have some gross slides for you. So the first slide is Stevens-Johnson syndrome. And again, notice the big difference between that and the maculopapular rash, where you literally see these bullae and blisters. Why am I going up there when you can't see it? Sorry. Blisters like that with large parts of skin involvement. That's going to lead you thinking more Stevens-Johnson syndrome or some sort of desquamating skin reaction compared to just a regular maculopapular rash. Here are some differentiation stuff that you're going to be thinking of when you consider a desquamating skin reaction. Again, we've talked about EMM. There's a whole bunch of other weird and unusual type of dermatologic manifestations of diseases. This probably should be in your differential. Things like acute generalized erythematous pustulosis, which I'm going to show you a picture of here coming up, fixed drug reactions, then infections, SSS, scalded skin syndrome with staphylococcal infections. If you have a peculiar type of psoriasis, erythrodermic psoriasis can often look like that. Bullous pempanoid can look like that. Lupus can even sometimes look like that. So again, there's a differential that's there, and it's not very narrow. And certainly if you consider any of this stuff and you don't feel comfortable making those diagnoses, getting derm involved is probably a good idea. But that's some of the stuff that's just going to be in your general differential of both Stevens-Johnson syndrome and TENS. And then we're going to talk a little about some of the other things that kind of fall under the rubric of drug-induced hypersensitivity syndromes. Here's a nice chart, and you'll have the slide of this that kind of talks about some of the differences between DRESS syndrome or drug-induced hypersensitivity syndrome, Stevens-Johnson syndrome or TENS, and then acute generalized erythematous pustulosis. And you can kind of just, I won't necessarily read the whole slide to you, but this is a nice little slide that kind of gives you an idea of if you have a hard time early determining the difference between the three, what are some clinical differences you might make to help the diagnosis. For example, AGEP tends to occur earlier than the other two do. Pustules are obviously going to be much more common with AGEP, but the good news is that organ involvement is actually pretty rare in those patients, so is mucous membrane involvement, whereas with Stevens-Johnson syndrome it's very common, so is lymph node involvement very common, and then even gives you some of the histologic path that you might see on histopath with the sample of that skin. As I said, one of the cousins that falls under the rubric of drug-induced hypersensitivity syndrome is hypersensitivity vasculitis, which fortunately is fairly rare, but it is a drug-induced hypersensitivity syndrome that is a vasculitis. It's cutaneous vasculitis that causes palpable purpuric papules. Sometimes I think dermatologists like the illiterate because they see a lot of P's and a lot of L's and stuff. Palpable purpuric papules. That is usually on the lower extremities, although any site may be involved. And you can actually suss the diagnosis of this if you take a sample and take a look at it, look for IgM and C3 complement on the capillary walls. There's actually official diagnostic criteria for hypersensitivity vasculitis. They usually have to be adults. Obviously, they need to have an offending drug in temporal relation to the symptoms. That palpable purpura, biopsy of the skin, then showing neutrophils around an arterial or venial. Then they also may have some other symptoms like arthralgias, a low complement level, because this is a vasculitis, and obviously an elevated ESR. The most common drugs associated with that are allopurinol, the penicillins, erythromycin. Again, here we go with Bactrim, thiazide diuretics, and here we go again with dilantin or the hydradantoins. So they have all been reported in causing drug-induced vasculitis. And here's a picture of what that looks like. Yeah, definitely a different pattern than maculopapular rash or even Stevens-Johnson syndrome, especially with these like individual kind of islands of lesions that kind of help you make that diagnosis. But again, getting derm involved and having them take a look under a microscope, I think, is the best way to go with this. There's another picture of hypersensitivity vasculitis. A cousin of that, which we're probably not going to see a whole lot of anymore just because A, we dose Coumadin better, and B, we're using novel oral anticoagulants a lot more, is warfarin-induced skin necrosis. I've actually seen this once in 25 years. It's a devastating but fortunately rare side effect of Coumadin, and the theory was always that it occurs early on in dosing warfarin in these patients. Remember that in patients, for example, have a DVT and PE, we usually overlap parental anticoagulant with warfarin in patients, and the clinical reasoning of that was always that because warfarin decreases protein C and S first before it decreases all the other factors, it transiently puts patients with warfarin into a hypercoagulable state, and that's why we always cover patients with parental anticoagulants with a DVT or PE. This is where this usually comes up as this rare effect, where you actually get occlusive thrombi into the small vessels of the skin and subcutaneous tissue because of this drop in protein C and protein S. But again, I've only seen this once, and maybe it's just because we're really good about covering patients with an acute DVT or PE with parenteral anticoagulation, but we don't tend to see this. This tends to affect soft tissue. The tissue becomes necrotic and often requires large surgeries to debride and or skin grafts and things like that. But it's usually adipose tissue like the breasts, hips, and buttocks. And here's a picture of someone with warfarin-induced skin necrosis. Fixed drug eruptions I've seen a few times, and they're kind of interesting. They're usually not particularly life-threatening, and they are exactly what they say they are. They're usually like a bullseye type of lesion that occurs at the same place, at the same location, every time that particular drug is used. And it's usually an erythematous plaque that then will turn off into a single bullseye, and then it becomes dark afterwards, and then kind of fades away. It can occur anywhere, but usually there's only one or two, and again, it's usually right at one specific part that always shows up at that specific part when the drug is given. Multiple drugs have been implicated, phenolphthalein, which we don't use much anymore, but tetracyclines, here we go again with Bactrim, nonsteroidals, and salicylates have all been known to cause fixed drug eruptions. And here's an example of a fixed drug eruption. And again, if this patient were to take this drug again, that exact same reaction would occur at that exact same place. Fortunately, it doesn't cause organ involvement and will go away upon removing of the drug, and there doesn't seem to be any long-term sequelae associated with that. Photosensitive drug reactions are not really hypersensitivity reactions, but I thought I'd put them here for completeness sake. And so we always tell patients, patients who are going to go to a malaria endemic place and they don't want to throw up on their anti-malarials, so we tell them, okay, well, your only other option is to take doxycycline while you're in country. And we say one of the problems with that is that thiazides and tetracyclines and these other drugs can cause photosensitive drug eruptions where skin that is exposed will have a dramatic reaction far beyond just normal sunburn or tanning. And so basically the surface tissues literally become hypersensitive to solar radiation and will develop reactions such as this. Again, wide variety of drugs have been implicated, but where I counsel patients about this is usually that scenario where someone's going to be going to a country that is malaria endemic and they need to either take prophylaxis before they go, or they will need to take someone they're there, and really the best drug for that is usually tetracycline antibiotics, but this is one of the price they might pay, and most malaria endemic places tend to be fairly sunny because they're near the equator, so it's something to think about. This is a picture of acute generalized exanthematous pustulosis. So again, this is that AGEP we were talking about. Again, you have sterile pustules, so if you actually were to culture these pustules, if you were to drain them culture, you wouldn't get anything. Fever's pretty common with that, and leukocytosis is as well. Again, systemic involvement is very rare, so you won't see acute kidney injury or acute liver injury, anything along those lines. You just get these pustules that will pop out, and they're usually on the trunk and sometimes on the legs, occasionally on the neck and face, but usually on the trunk and the legs. As you can see, the etiology is 90% of the time it's caused by drugs, other things as well. And again, as far as what drugs, there's 1 million drugs that have been reported to cause AGEP. Again, typically starts on the face and the armpits and groin and becomes more widespread. A rapid appearance of red skin studded with small sterile pustules, and interestingly, there tends to be a lot more disease in skin folds, so like in the crack between the arms and the elbows and stuff like that. It lasts for 1 to 2 weeks, and then the skin peels off as it resolves, and very rarely is systemic involvement occurring. So again, you definitely want to stop the drugs involved, but it doesn't tend to progress onto life-threatening problems in these patients. Causes of AGEP, I've got some of the ones listed for you then. Again, Bactrim is definitely in there, so if you get the feeling that Bactrim can cause pretty much every drug-induced skin problem on earth, you're right, it can. Fortunately, it's all pretty rare, and it's still a pretty good drug to use. But quinolones can cause it, the penicillins, diltiazem, the azole antifungals, and myself and another resident, we actually published a case of bupropion-induced AGEP 7 or 8 years ago, and it was a pretty classic case. The patient had been on bupropion for about 10 days, and then developed this rash in the face and the legs and in the creases of the elbows, and it looked exactly like that picture was. And there was actually no previously reported cases of AGEP from bupropion, so we actually published a case report on that. There are some infectious causes of AGEP, including parvovirus, chlamydia, and CMV, and we actually tested for all 3 of those things in this patient and it was negative. So that you would want to consider that too if you saw that kind of rash spring up on somebody. So, all these terrible, wouldn't wish this on my worst enemy sort of reactions, what do you do once somebody's gotten them? Well, stop the drug, okay? And I would say never re-challenge. I was always taught that if somebody develops a severe skin reaction to a drug, there's probably almost no indication for that drug that would outweigh the risk of a life-threatening hypersensitivity reaction like this. So, never re-challenge. Can you desensitize these patients? No. Okay, desensitization works for IgE-mediated reactions. None of these are IgE, so no, you can't desensitize patients. Even small doses may trigger the reaction again. So say, well, let's give you a 250 of amoxicillin and see what happens, or let's give you a half of a Bactrim DS and see how that works. Don't do that. Okay. Supportive care, just like everything else, is the mainstay of therapy. It's what happened to my patient with lamotrigine. We blasted her with fluids, high doses of saline. We did supportive care for her pain, supportive care for the skin lesions. For her, it was quite itchy, so we had her on antihistamines and all sorts of stuff like that. But she was getting both mouth involvement and both eye involvement. We got an opto consult, and they were seeing desquamating of the inner eye and actually some of the cornea. And I'm not an ophthalmologist, and I certainly don't pretend to be one, but when the note says corneal melting, that don't sound good to me. So I was like, okay, I think it's time to send that person to someone who handles corneal melting, because we're not one of those people. Should you give steroids? This is an allergic reaction. Should you give steroids? The answer to the question is nobody really knows, because, of course, this is rare enough that it's going to be almost impossible to do an actual decent clinical trial on. What most experts would say is, yes, if the patient has significant clinical worsening or life or organ-threatening symptoms, you probably should put the patient on steroids. We did start steroids in our patient. So how much? Nobody knows, so it's probably reasonable to use our standard 40 to 60 milligrams of prednisone or 60 milligrams of methylprednisolone intravenously every 8 to 12 would all seem to be reasonable. But again, keep in mind that it's largely supported only by case series and case reports, but experts in the field say that yes, this is an allergic reaction. If the patient has life-threatening symptoms, we probably should put them on some sort of anti-inflammatory, and steroids kind of lead the list. What is your prognosis, especially for Stevens-Johnson syndrome? There actually was a validated score that was published back in 2009 called the Scorton score. And it's fortunately pretty easy to look at. You don't need any skin biopsy findings or anything. Just age, the presence of malignancy, total of body surface area of detached epidermis, their heart rate, BUN, glucose, and bicarb. And each one of those gets a point. And basically, if the point is 5 or greater, if they have 5 or more there, they have a 90% mortality. So I would say anything with 3 or more, you're probably going to want to be thinking about sending the patient to a specialized treatment. Have people tried other things? People have tried cyclosporin. If steroids don't work, I have no experience with this because I've never seen this being done, but there are case reports of people using cyclosporin in patients who did not respond to steroids. The dose that's most common in the literature is 3 milligrams per kilogram per day for 8 to 21 days. And do be aware of the side effects, especially if somebody has acute kidney injury and drug-induced hypersensitivity syndrome. Cyclosporin may not be your best option there. Even with monitoring levels, the chance of nephrotoxicity is fairly high. Other people have tried IVIG. Again, there's a few case series to support, and the dose is 500 milligrams per kilogram per day for 5 days. And so it's certainly reasonable to consider. One thing I want to make sure we're all kind of understanding, a lot of my physicians feel like IVIG has no side effects. I know it's expensive, but I never seen anyone have a problem with it. And that's actually not true. AKI is not unheard of with IVIG. It's definitely reported in the literature. I've seen it a couple of times. So IVIG does have side effects associated with it. So I'm not saying don't use it, but don't feel like, that we're not going to hurt the patient by giving it to them. There is a chance you can cause AKI in these patients. N-acetylcysteine, hey, why not? N-acetylcysteine, let's give it a shot. Again, it's a theoretical benefit just because of the antioxidant effects, may have an anti-inflammatory effect. It's the same doses that they've used to treat acetaminophen overdoses, but again, it's all theoretical, but a few case reports are out there. I probably would not recommend trying it, again, just because there's even less data to support N-acetylcysteine than cyclosporin or steroids or IVIG. So it's theoretical, but again, I would not recommend using it. So that's one terrible, disgusting, bad part of drug use and adverse drug reactions. Now we'll talk about another one, which is acute interstitial nephritis. So this is an allergic reaction. This is a hypersensitivity reaction. So acute allergic interstitial nephritis presents with some standard symptoms: fever, rash, arthralgias, eosinophilia, and then often eosinophiliuria as well. On the UA, what are you likely to see? Microscopic hematuria, pyuria, non-nephrotic range proteinuria, and then eosinophiliuria. It's always hard for me to say. Now, with my physicians, one of the things that if someone has acute kidney injury and they might be on a drug that might be implicated in IN, one of the things it seems like we always do is get urine eosinophils. Let's check urine eosinophil. If it's high, that tells us what's going on. And so one of the big questions that my nephrologists are continually telling my internists is, does urine eosinophils actually help in the diagnosis of acute interstitial nephritis? And the answer is, no, it doesn't. It's found in many causes of kidney injury, just not including acute interstitial nephritis. A couple of studies have actually looked at this, and if you use a 1% of eosinophils in the urine, the sensitivity is only 30% and specificity at 68%. And even at 5%, the cutoff, the negative predictive value is only about 80%. So, I'm not saying don't ever draw urine eosinophils or ask for eosinophils to be drawn to help make the diagnosis, but don't use that test in isolation. Use it with the patient's other symptoms, because most of these patients will have some systemic symptoms, okay? Also look at the UA, and if worse comes to worse, get a renal biopsy, because that really will tell you the diagnosis in most cases. What drugs cause acute hypersensitivity interstitial nephritis? Penicillins. In fact, the classic penicillin, not always taught, has caused it, is methicillin. It's one of the reasons why methicillin was taken off the market. Nafcillin does cause interstitial nephritis, probably at a greater rate than most other penicillins, but all penicillins and cephalosporins have case reports of it causing. I've actually seen at least one case we're pretty sure was due to Cipro. We actually didn't get a biopsy to recommend it, but the patient had a fever. He had high systemic eosinophils and urine eosinophils, and we stopped the Cipro and started steroids, and he got better really quick. So we were pretty sure it was the Cipro in that patient. here we go with Bactrim again. Non-steroidals, allopurinols, and others. So, it is often drug caused, but it's not always drug caused. Certain infections can cause it, including Legionella and CMV. 8% of the time we have no idea what causes it, and 6% of the time it's another outcropping of another systemic autoimmune disease like sarcoidosis or a tubular interstitial nephritis. So again, drug causes of AIN, I'm not going to bore you guys to death talking about all of them. Again, pointing out that penicillins, quinolones, cephalosporins, Bactrim have all been reported. Non-steroidals have all been reported. We always know not to give non-steroidals to people that can cause acute kidney injury. This is actually one of the mechanisms by which non-steroidals can cause acute kidney injury. So keep that in mind. Diuretics can, and a wide variety of other drugs, but there's one drug I really want to point out to you guys because I think it kind of flies over us kind of high, wide, and handsome when we think about drug causes of acute kidney injury, and that's proton pump inhibitors. So usually when people ask me, do proton pump inhibitors cause kidney problems? Most of the time the answer is, well, no. I mean, millions of people take them and we don't have a lot of problems, so do they cause it? And in fact, the answer is, yeah, they do. Proton pump inhibitors are often overlooked cause of acute interstitial nephritis. This is a paper that just came out a couple of months ago, actually. It was a big meta-analysis that looked at 2.6 million patients on proton pump inhibitors. It was obviously a big database retrospective study, and looked at the risk of developing acute kidney injury in patients on proton pump inhibitors compared to controls, and did find that patients who are on proton pump inhibitors have a significantly, about a 44% relative risk increase in developing both acute kidney injury and this is the big one, look at that relative risk increase, a 261 increased risk of developing acute interstitial nephritis compared to controls. So proton pump inhibitors, again, I'm not saying they're not safe and you shouldn't be used in appropriate patients, but this is yet another weirdo side effect of proton pump inhibitors that I think most providers and most patients are just unaware of. Well, it doesn't have anything to do with the kidney. Actually, it probably does have something to do with the kidney. Course of AIN, the renal damage is not dose dependent, and it may take weeks after the initial exposure of the drug. Usually the normal course, or what you're usually going to see, is that it occurs over several months to a year after use. And then as early as 1 week after the medication has begun, you can get actually biopsy positive AIN. Again, please keep in mind that just checking a lab doesn't suss the diagnosis of AIN, that many of these patients are going to have things like fever, serum eosinophilia, rash, and again, in your UA, look for some of these other things that we've talked about as well, in particular white blood cell cast, which for many other diseases besides AIN may be an important clue that dictates the need for biopsy in these patients. I wish I was a pathologist that can tell you what this looks like, but the slide says that it's eosinophils and acute interstitial nephritis, so I'll trust that you guys can see that a lot better than me I can as a pharmacist. Treatment, discontinuation of the offending agent. I'm often asked about, okay, I really did have a patient who has a history of nafcillin-induced acute interstitial nephritis. Can he be on penicillin again? And the answer is, yeah, he probably can. The cross-reactivity of this type of allergic reaction is actually vanishingly rare. And so I actually would not be all that nervous about starting another penicillin or cephalosporin on this patient. So cross-reactivity with the other compounds should be low. We will usually put these people on steroids if we suspect or have sussed the diagnosis. And again, kind of your standard doses of prednisone for a couple of weeks, or IV methylprednisolone at bigger doses for 3 days. As I've seen both of them actually over the years. Prognosis, they actually usually do pretty good. Most patients recover full kidney function within 1 year. They're less likely to do so if the effects last greater than 3 weeks or they have an advanced age onset. So that's kind of my whirlwind tour on non-IgE mediated reactions. And again, I don't want everyone to run out of here terrified to ever prescribe Bactrim in anybody ever again. No, again, remember, millions of people take these drugs with no problems. These are relatively rare adverse effects, thank goodness. But they do occur, and I think most of us have probably seen them. I've seen several of them over the years of my career. So they can occur, they can be devastating, and I think the trick for physicians and providers is to make the diagnosis, because while it's often drugs, it can be other things. It could be infections and things along those lines. And then once somebody does have some sort of skin reaction, trying to narrow it down into, is this Stevens-Johnson syndrome? Is this AGP? Is this vasculitis? Helping to do that. Again, who can help with stuff like that? Obviously, dermatologists are the experts in this field, and especially for biopsy doing and looking at can be very, very helpful. And then certainly the actual drug, once anyone has any of these reactions, is contraindicated after the episode. And that's kind of what I got for you. Again, as always, if you have questions or you run into a cool case that you're like, I didn't think about that till I walked out of here, here's my email address. Feel free to email me anytime you want. And for those of you who follow on Twitter, here's my Twitter address. And again, all I ever talk about is medicine and music, so don't have to worry about me talking about politics or anything. Yes, sir.
So when we're getting ready to perhaps prescribe carbamazepine or allopurinol, would we find anything in our EPIC record to warn us to do HLA typing, or would the pharmacist catch it before he or she gives the patient the prescription?
Great question. Short answer to both questions is I don't think so. It doesn't come up as an EPIC report on our EPIC at Methodist. And while I think there's some good pharmacists out here who have caught that, this is still pretty under the radar, even though these warnings have been on the package insert of these drugs for probably now 10 years. It's just not something that falls, it's not something that either providers or pharmacists are really aware of. And I actually have a student in the audience. She will tell you that I wish pharmacists got more training in this area, more training in drug allergy, but we're lucky if they get a lecture in pharmacy school on it, which is kind of weird because that's a lot of the questions we get. So I wish the answer was there's a great safety net to help you with this. There isn't. Yes, sir.
A very nice discussion. I was troubled by a table. I don't know if you mentioned it, but
yes, sir.
On like your 6th slide, there was talk of an eruption to a delayed maculopapular rash from a sulfonamide antibiotic. It would take somebody with more courage than me to say, oh, let's try it again. I think you're right about many of these processes being part of a spectrum, and that second time around, I think, can be a lot nastier than the first, and I would be really reticent. May reuse under type 4B. I wouldn't reuse it,
and that's fair enough.
I would guess that my friends in infectious disease would successfully find some suitable alternative.
Right, and most of the time you can, absolutely. Yeah. But what the literature shows is that patients who have a simple maculopapular rash to Bactrim seem to tolerate the second or third time down the road at a pretty high percentage.
Yeah, I wouldn't dispute that. I'm just thinking.
Yeah, you wouldn't have the guts to, and in most cases, neither would I. Because if I can find some other way, even if something like PCP prophylaxis, and they had a rash to Bactrim, in the old days, in the bad old HIV days, what did we do with all these patients? Is we'd put them on a rapid desensitization. Remember that, where they'd go home on 2 weeks of Bactrim, and you cross your fingers they didn't develop Stevens-Johnson syndrome. Today we have other alternatives and things along those lines. Absolutely. Yes, sir.
So if I have a patient with gout, an Asian, and thinking about allopurinol, would it be better to test or go ahead and use Uloric? Have you had any?
It's a great question. So yeah, as I understand it, Uloric does not cause acute interstitial, or hasn't been reported to cause acute interstitial or drug-induced hypersensitivity reactions. That would not be unreasonable to do. It depends on where's the cash going to come from? Because the patient's either going to pay for the super expensive genetic test, or they're going to pay for the super expensive alternative to allopurinol. So I think either way, they're probably going to pay. So Febuxostat's supposed to go generic, I think, in 2019. And if that's the case, then hopefully the price would come down to the point where it probably doesn't matter.
And your slide also said Caucasians, so that opens up everybody.
It does, but the package insert, and again, this points out the fact that Caucasian mutation on that allele is super duper rare, whereas the mutations on the other HLA complex is more common in those Asian populations. So I think that's why the package insert specifically calls out Asian populations, sort of thing. So that's what I would focus on.
Thanks for the discussion. One question up here.
Sorry, I apologize.
If you had a patient that had a reaction to Bactrim, do you know if there's a cross-reaction to sulfonylureas?
Oh, I love that question. Thank you so much. Yes. So the question is, if someone has a reaction to Bactrim, can I use thiazide diuretics in them? Can I use loop diuretics in them? Can I use sulfonylureas? And the answer is yes, yes, and yes. Why? Because both the type 1 reactions and the Stevens-Johnson type 4C reactions are mediated by an aryl amine group that is only on sulfonamide antimicrobials. That aryl amine group is not on hydrochlorothiazide, Lasix, sulfonylureas. So non-antibiotic sulfonamides have no cross-reactivity. People have a reaction on Bactrim. And that isn't just Geoff Wall saying that. There was a great paper that came out in the New England Journal of Medicine in the early 2000s, and it was a British paper where they took a look at a whole bunch of people who had a reaction to a non-sulfonamide antimicrobial like Lasix, thiazides, went backwards in time to see, to take a look at their allergy history, and found that you were more likely to have a reaction to thiazides, Lasix, all these other drugs if you were allergic to penicillin than if you were allergic to Bactrim. So there's no cross-reactivity.
Hello.
Yes.
So
Ma'am,
I have two questions.
Yes,
One, for rifampin, is it linked to one of the, for rifampin,
Yes,
is
ma'am.
it linked to one of the Korean HLAs?
It is. I see
You don't know which
rifampin
one?
so
Okay.
rarely, but
That's
yes,
fine.
yes.
Okay,
yes, yeah,
that's,
yeah.
and then do you know on the current like 23andMe profiles, are the allopurinol and carbamazepine HLAs tested on those?
No.
They're not?
And
Okay,
so
that's why I couldn't remember the last time I looked
that's
at
a
one of
great
those.
question, because now for $59.99, right, your patients can get a lot of this genetic information. Many of these alleles and many of these pharmacogenomic things are not part of the standard 23andMe sort of stuff. They're actually much more directed for things like risk factors for breast cancer and stuff like that. So now, of course, you know, there are multiple companies out there who will be happy to take your money and have you swab your mouth and go and get a report that says you are low, you know, you don't make this cytochrome P450, you don't make this serotonin transporter, et cetera, et cetera, et cetera. I would probably, I don't want to say I would discourage my patients from doing that. If they want that information, that's great, but I'm not sure how it's going to help you make decisions on most antibiotics, because this specific stuff isn't going to be on there. And there's a lot of data, and we're going way off topic here, there's a lot of data in a lot of excitement in the psychiatric realm that your ability to respond to antidepressants is genetically determined. And so, like I said, for $59.95, you can get a pharmacogenomic profile done of you, and it'll literally come on. I've seen these reports. It has a report that has a red light, a yellow light, and a green light. And it says, these are the good antidepressants for you, the green light ones. These are, you know, they aren't going to work or they're going to cause side effects, and you absolutely shouldn't use the red ones. Do you know how much data we have on using that way of dosing antidepressants rather than throwing a dart at a board? Zero. Okay? So until that data comes out, I have not been all that jumping up and down to make decisions based on that. That's my personal opinion. So. Thank you very much.